In this voiceover, we will take a look at the radiological and surgical procedures that are used in the care of clients with peripheral arterial insufficiency problems. Remember that it's more important to concentrate your efforts on the care of those clients, both pre and post-op, rather than the procedures themselves. But I think if you can look and understand a little bit about how the procedures are done, it helps you to think about the care you need to provide. We also, in this voiceover, will take a look at the care of the client with amputations, because many of these clients end up having an amputation related to their vascular problem. Okay, so here are the procedures, either done in radiology or in surgery, and most of them are done by entering a large artery, usually the femoral artery, and working that way rather than an incision in the skin. And that's been a great advancement over the last several years, which of course is better for clients in terms of recuperation. When you think about all of the complications of general surgery. So the first one, percutaneous transluminal angioplasty. You've seen this before. You've seen this before in cardiac. It's the same idea. So it involves inserting the catheter through usually the femoral artery, putting in a balloon, inflating the balloon, which then cracks that atherosclerotic matter and breaks it up, therefore opening up the vessel. Now, this is often done in conjunction with a stent, which is balloon angioplasty with stents. So after they inflate the balloon and crack the atherosclerosis and open up the vessel, they will probably leave a stent in there to keep it open for the long term. In radiology, they can do what's called an atherectomy, which is removing that plaque by laser. They can also do some cryoplasty, where they go in with liquid nitrous oxide. So it changes from liquid to gas, which expands the artery and again opens it up. And then we have some more traditional options like peripheral artery bypass graft surgery. So those of you that have been on the vascular unit have seen tons of this. So this can be done sometimes again through the femoral or a main artery, and sometimes they still, more often probably still, perform this surgery through an incision. So think about the bypass as driving down the road and coming upon a detour. There's an accident or there's road work and you have to go around it and you have to take another route. And that's what the bypass graft surgery does. It creates a permanent other route. Sometimes they use a client's own vessel that they've taken from elsewhere in the body, or sometimes they put a synthetic vessel in. And so this then reroutes traffic, so to speak, to restore blood flow to the lower extremity. And there's a nice picture of that on the slide in the top right-hand corner. The final procedure that I wanted to just mention is the endarterectomy. And we talked about this with stroke. We talked about it in terms of a carotid endarterectomy. Same thing here. They would surgically open the artery, probably through an incision, and pull out that plaque, and then sew it back up and put kind of a patch over it to keep the vessel strong. So on this slide, I just wanted to provide you with a couple videos so you could visualize what this looks like. And again, I think it just helps your understanding of the care of the client afterwards. So the first picture on the left, if you click on that, if you're in slideshow mode, you can double click on it If you're not in slideshow mode, you can right click on it and open the hyperlink, and there's a very brief YouTube video of a balloon angioplasty with a stent placement. The one on the right is a percutaneous transluminal angioplasty. So I just leave these here if you're interested to take a look. They're kind of fun to watch. Okay, so here is what is really important about those procedures, your care of the client post-procedure. So first and foremost, what's huge, guys, is really to monitor distal circulation. So what I mean by that is you want to monitor peripheral perfusion below the point of surgery. You want to be sure that that vessel is still open and that blood is getting to that point beyond the surgery. So you're going to monitor CMSTs, color, movement, sensation, and temperature. You're going to look at what your baseline data was. So for example, if the client had a weak pulse before surgery, do they at least still have that weak pulse? We're hoping for a stronger pulse, but no pulse would be evidence of a huge problem. So it's important to know where the client was beforehand. If the client definitely had a good pulse before surgery, perhaps a pedal pulse, and now they have a weak pulse, well, that's a problem. That's a change, right, from baseline. We can use the opposite limb that was not operated on or did not experience the procedure to make a comparison. Please note that a loss of pulse, a change from baseline, a change in the Doppler sound requires immediate intervention. So this means that the procedure may have failed and we don't want any ischemia or death of tissue to occur. So other complications are bleeding. Definitely, you're performing, well, we're not, but someone is performing a procedure on an artery, and so if something happens, the bleeding can be very significant. So we want to watch for bleeding at the insertion site or at the incision site, either way, depending on how the procedure was done. We want to make sure there's no evidence of a hematoma at that insertion site or at the surgical incision. We want to always monitor for thrombosis. And so going back up to that first bullet about distal circulation monitoring, that's one thing that can happen. A clot can form in the vessel after the procedure, and then that might be a reason why you wouldn't palpate a pulse or see good perfusion, cap refill, color, warmth, all those things. If a clot forms, then a clot can become an embolus and travel, right? So there's always that worry. And of course, those are things that are common to any surgical procedure, but really important in these procedures. We can also look for compartment syndrome. Now, you've talked about that in other places with fracture and with shock and with burns. So there can be enough sensation, or edema in the area that it can actually block off that vessel and cause compartment syndrome, which will affect distal perfusion. We need to monitor for infection, and this is a really common reason why these procedures and surgeries often fail. And so again, those of you that are currently or have been on the vascular unit, you see a lot of clients come in that had perhaps a bypass, and they came back because it's now infected or the graft is infected. So all of those things, localized infection, systemic infection, so we're looking at fever and all those things you know by now about how to assess for infection. Please note that any sharp increase in pain, any loss of a previously palpable pulse, or a change in sensation, pallor, cyanosis, coolness of an extremity requires immediate intervention on your part. Okay, because we need to preserve perfusion. We don't want death of those tissues. Here are some of the post-procedure nursing interventions that you can employ to prevent those complications that we just talked about. Well, first and foremost, pain management. This is a very painful procedure, and you want this client to get up and walk around. You want movement to prevent stasis and thrombosis. So they're not going to get up and move if we don't address their pain management. You know, remember that they may have been in quite a bit of pain before the procedure, and they may already have been taking opioids. So we want to think about tolerance. And so what are we giving them post-op as compared to what they were taking before the procedure? You know, and sometimes we're just still not really good about pain management, and we worry about dependency. But we have to really think about this. Is what we're giving post-op at least equivalent to what we were giving pre-op? And remember that they may have built up a tolerance. They may have been taking opioids for a long time, suffering with this condition. Turning and positioning and getting them out of bed and moving, huge. Again, prevents stasis, prevents thrombosis. And again, that's pretty basic post-op care that you guys learned way back when. We don't want to keep the knee flexed, so that just goes to a kinked garden hose. Remember my garden hose analogy. And we don't want prolonged sitting with dependent legs. Again, that's the flex knee position, and we're not going to get fluid back to the heart. It could collect and build in those legs. And those things are not going to promote good perfusion. Lying on the back with legs elevated above the heart is good and probably better than sitting in a chair for long periods of time. So for these clients, what's best is to have them supine with legs elevated above the heart, but getting up frequently, getting up to walk to the bathroom, getting up to walk around the unit. Elastic compression devices are also used to help limit the edema and get the fluid back to the heart, and we often call those TED stockings. One of the things that I think I probably didn't talk about earlier when I was talking about surgery and bypass, it just occurred to me, it's a little out of place here, but I just want to say it, is that often when a client has bypass surgery, we refer to the type of bypass by the location of the bypass. So if the blockage was between the iliac artery and the femoral artery, not a good example, we're talking about lower extremity, right? If it was between the femoral artery and the popliteal artery, then we could call it, and you've seen this, a femoral popliteal, or they usually say a fem-pop bypass. And I guess, I'm sorry, I'll go back and correct one thing I just said. Anything below the aorta is what we're talking about here. So if the bypass is between the aortic and the iliac artery, you've seen it or will see it as an aorto-iliac bypass. So just something that I wanted you to have that I just didn't say earlier. If clients do not have complications and things go fairly well, and sometimes that depends on their premorbid status, what their condition was prior to the surgery. It also depends on if they're diabetic or they have other comorbidities. But if things go well, they're usually discharged in 3 to 5 days. Unfortunately, we do see a lot of recidivism or return of these clients for infection or failed procedures. So we want them to go home on their very best foot, no pun intended, and we want them to think about modifying those risk factors that got them there in the first place. So we really will try to work on smoking cessation. You know, you can't make somebody stop if they don't want to, but it should be a focus at least of education and getting them to contemplate this change. They probably will still remain on antiplatelet treatments to prevent a reoccurrence of plaque buildup and platelet aggregation. And usually if the procedure was below the knee, it requires more guns, and they kind of do both. They'll do maybe a silostazol and aspirin together. We want to have them get into a regular exercise routine. So something they're probably not going to want to do, you know, they're uncomfortable, but it's just so essential that there's that movement that promotes good blood return and movement through the blood vessels themselves. So they're going to progressively work up to that, and you know, walking is probably the best exercise. We're going to talk about progressive exercise in a few minutes with amputation, and really it would be the same type of process, so I won't say it twice. We want to teach them meticulous foot care. We need to teach them CMSTs and how to observe and what symptoms they need to report immediately to their provider that may indicate decreased perfusion below the site of the fix or the surgery or procedure. Nail care, you know, of course, cutting straight across, and anything that would cause an opening or an introducing of infection we would want to prevent. So clean cotton socks or wool socks, well-fitted shoes, you know, inspecting every day. All those things we teach diabetics are really, really important as well. Sadly, clients with peripheral arterial insufficiency problems often end up with an amputation, and so sometimes it's done directly as the fix, or sometimes it happens after a failed procedure like one of the ones we just talked about. So a little diagram here just kind of gives you some of the different types of amputations. Very commonly we see the foot first. If things don't get better, if lifestyles don't get modified, if there are many comorbidities, if surgeries don't take, we see it progress up the leg. So we're pretty familiar with the terms above knee, below knee. There are some more official transfemoral or transtibial here, but above knee and below knee are good for me. If the limb is taken at the joint, it's called a disarticulation. So you may see a hip disarticulation or a knee disarticulation out there. The goal of care here is to preserve the extremity length, and in doing that, preserve the client's function. So if you just lose a foot, it's going to be a lot easier to get a prosthetic going and go through rehabilitation and maintain your mobility than if you have a hip disarticulation. It's going to require much more rehabilitation and care. And if you have a client that doesn't do well post-op for whatever reason, and they have to keep coming back and having that limb amputated more and more and more, it really affects their overall picture and their survival. So we want to preserve the length and their function, while in the same sentence removing the infected and the ischemic tissues so that we can have healing. Again, not easily done in people with comorbidities, especially your diabetics. this can also occur as a result of peripheral arterial insufficiency in the upper extremities. I don't want you to think it's specific to lower, but the context that we're learning about it is just lower. But there is a table in your text written down below that you can take a peek at that also shows amputations of upper extremities. So amputations are very common in people with peripheral arterial problems, and they account for most lower extremity amputations, but also know that things like trauma, diabetes, tumors, and some of the other things mentioned below can also lead to an amputation. And again, we're just talking about it in this context. However, the care of a client with an amputation is the same no matter what the cause of it was. When we think about the nursing process and specifically nursing diagnoses, we certainly will look at some of those diagnoses we've already talked about, like impaired skin integrity or ineffective tissue perfusion. I also threw in there physical mobility, but two that are on your objectives page that I think we haven't looked at yet are disturbed body image. And this is huge post-amputation, related to loss of body part, and the evidence that I gave was that maybe the client might refuse to look at the limb. We'll talk a little bit more about that in a minute. Pain we've talked about before, but this can be more of a chronic pain related to phantom limb sensation. And that's a very real phenomenon that we also will talk about a bit more in a minute. And the client will actually report to you feeling pain, perhaps in a foot or a limb that's no longer there. So these are important things to consider in the planning of your care. Our goals of care certainly go back to preserving function, promoting relief of pain, and helping clients get the very best they can out of rehab, helping them to cope with the changes in their body. It's a loss of a limb or part of a limb. Clients can go through the stages of grief in addition to just having trouble with their body image. So it's important that we consider a well-rounded, holistic approach to planning the care of these clients. In terms of nursing interventions, we should start with pre-op teaching, and like with all pre-op teaching, how we set them up beforehand for success will definitely have a relationship to how well they succeed afterwards. So in addressing the grief and the loss and the coping and the body image issues, we need to be very careful about how we talk about the amputation to the client. And so one of the terms that is rarely used, or we don't recommend that is used anymore, is the term stump. So just doesn't have a great feel or connotation. So the preferred term is residual limb, which is a much nicer way to say it. So over the years, as I've taught this, I have tried very hard to always use that term. We want to explain to them beforehand what they can expect with rehab and how difficult that will be, how challenging that will be, how hard they will need to work to get themselves back to as close to their lifestyle as before, that it's not a passive thing, it requires their active engagement. It's kind of like you're learning in nursing school, right? It's not anymore a sit in the class, open your head and I'll pour in the information, but you have to actively engage in the process to get something out of it. You'll want to talk with them about what will happen post-op in terms of the dressings and the prosthetics that will be used, and we'll talk a little bit about that in a minute. you'll want to have them prepare a little bit and do some upper extremity strengthening, because they may need to walk with crutches, they may need to wheel a wheelchair, they may need to transfer on a slide board, and those things will require some greater upper extremity use than probably what they were doing beforehand. You'll also want to address the phenomenon of phantom limb pain and sensation. And so in a minute we'll go over that again in a little more detail. Post-op interventions, first and foremost, involve monitoring for complications. So the first one that comes to mind is hemorrhage, because we want to look at the incision site and observe that very carefully. There should be a tourniquet at the bedside in case the incision were to open. Remember that an amputation involves the severing of major blood vessels, including arteries. So if a client's incision opened up, they could bleed out very quickly. And that's something a few years ago we saw in clinical on the vascular unit, so it does happen. So there should be a tourniquet at the bedside and very present monitoring for hemorrhage. You also will want to look at the dressing. Is there blood on the dressing that probably isn't changed for a few days till the surgeon comes and changes it? Is the drainage getting larger? Are they having symptoms of bleeding? So is the pulse increasing, the blood pressure lower? Are they looking pale? Those kinds of things. So you would look all the way around at hemorrhage. We want to be careful about edema for a couple of reasons. If there is a great amount of edema at the amputation site, it will affect healing, but it also will delay a prosthetic fit. So this is the reason that we will not want them to sit dependent with their knee flex, just like with the surgeries and procedures we talked about earlier. We will want to promote that return of fluid back to the heart and not have it sit in the most distal place. So we also will look at the incision and the extremity itself for evidence of infection, which can occur with any surgical procedure. And we will want to be concerned with joint contractures. So just like we don't want a lot of edema, we don't want to see the joint that will be needed for the prosthetic use to become contracted. That will delay or prevent the use of a prosthetic device. So again, avoid sitting in a chair for more than an hour at a time, and assist these clients to lie on their stomach for about a half an hour 3 or 4 times a day, and that prevents flexion at the hip, and that's really important to good prosthetic use later on. We are going to need to address phantom pain, and what phantom pain is about, we're not completely sure, but because the nerves, the peripheral nerves, are severed for some reason, even though they're severed and they may be gone, there's still a message getting to the brain that there's pain there. And sometimes it takes a long time until healing is way beyond them for that message to stop getting to the brain. So it's just kind of like a crossed wires going to the brain. Remember that when you have an injury, when you touch the stove and your hand gets burnt, it's not the hand on the stove that's telling you you're in pain, it's your brain telling you in your pain. So it's that impulse that travels to your brain and then back down to your hand to say, ouch, that hurts, right? And so it's the same in this way, and it just takes a long time for the nerves to reroute themselves and straighten themselves out. There's something new that I've heard about, and your text actually mentioned it, so it was fun to see it there, called mirror therapy, and that sometimes this helps with body image and coping for clients to be able to look at their residual limb. But in this case, and again, not sure why or how, but it may provide some visual feedback to the brain that will help those nerves to reroute sooner. Then the last thing on this slide we'll really go into in the next slide, and that is residual limb shaping. Residual limb shaping is as important as preventing contractures and edema in terms of early prosthetic fit. So we need to shrink the tissues at the end of the residual limb that will fit into the prosthetic device, and get that tissue healed and ready. That's what maturation means. We need some tough tissue there on the end that can support the wear and tear that the prosthetic device would put on it. So we want to reduce edema, minimize pain. We want to support the soft tissues. And so this is done right after surgery with some type of compression device that's applied. So very typically you will see ACE bandages applied over the dressing. Sometimes they use casting, although I've not seen a lot of that. Your book does mention it. And sometimes you see a shrinker device down below. Now, although we're going to try to use the word residual limb, the common name for this is often a stump shrinker. And so it's tight like a TED stocking. It's a compression device that helps to maintain circulation in the same way that a TED stocking does. And just like with your TED stocking, you need to remove it several times a day. Look at your skin, observe it, clean the skin, dry it well, and reapply it so that we preserve circulation. This is really important if an ACE bandage is being used, because they typically move around and get displaced, and you have to rewrap them so that there's a nice snug fit and edema isn't accumulating kind of in the middle where the ACE loosened or moved away. So again, this begins immediately after surgery. The devices that you use to provide the compression may change over time, but the idea is to get the limb in shape for a prosthetic device as soon as possible after surgery, because that's our goal here. And eventually the shrinker turns into just kind of a sock that goes on over the well-healed residual limb before it fits into the prosthetic device, just like a sock in a shoe. This final slide is a little information on do's and don'ts, and it just kind of goes back to what we talked about, good positioning and positioning so that we prevent complications like swelling and contractures. And I cringe a little because it refers to the word stump. This picture's probably pretty darn old, but it does the job. So remembering to have them lie prone or on their stomach, not having the residual limb dependent, not elevating it on a pillow, all those things that can cause dependent edema or contractures. So this concludes this voiceover. And the next time we are going to move into some arterial insufficiency above the extremities at the aorta.